Uh, Good afternoon, everyone here on the East Coast, and good morning, everyone on the West Coast. Good evening to anybody farther east than here. I'm really excited about today's eJournal presentation. We get a lot of great presentations from our cytopathologists, but I really look forward to the ones from our cytologists. They really tend to have a unique perspective on the cases that we see, and particularly the FNAs. I know they're involved traditionally in GYN cytology, but the FNAs, at least in our institution, and I imagine up at BIDMC, they are really involved in thyroid FNAs as well. And today we have Dr. Seyedreza Mousavi. Dr. Mousavi holds ASCP board certifications in cytology and molecular biology and is currently on the staff at Beth Israel, the one in Boston, not the one here in New York. It's just part of the Harvard Medical School. He's been very active within the ASC. He's an active member of the eJournal committee since 2021. He was previously on the case study committee from 2020 to 2022, and he served as the vice chair from 2022 to 2023. He presented the basic cytomorphology as junior faculty during the ASC cytopathology crash courses in 2023 and 2024. And he's worked a lot in quality improvement, which is, as anybody who's been involved in thyroid FNA knows, that's something we could always use. Since 2021, he's actively participated as a presenter and moderator in scientific presentations as part of ASC, ASCP, ASCT, and USCAP. And his work at ASCP annual meetings has reserved 5 Blue Ribbon finalist selections and the Best Basic Science Poster Award for his research on genetic alterations in pancreatic neuroendocrine tumors. And finally, at ASCT, he's presented as a recent graduate finalist in 2021 and delivered sessions on pancreatic lesion evaluation in 2023 and 2024. But today, he will be talking about thyroid FNA, and I'm really looking forward to it.
Thank you very much, Dr. Heyman. I will start with introducing Dr. Nishino, senior author of the article. Dr. Michiya Nishino is the director of head and neck pathology and program director of the cytopathology fellowship at Beth Israel Deaconess Medical Center, and he is associate professor of pathology at Harvard Medical School. He is an associate editor for cancer cytopathology and also serves on the editorial boards of the Journal of the American Society of Cytopathology, Cytopathology Journal, Head and Neck Pathology, and seminars in diagnostic pathology. He was a lead author of chapters in the 2nd and 3rd editions of the Bethesda system for reporting thyroid cytopathology, including a new molecular testing chapter for the 3rd edition. His primary clinical and academic interests include surgical pathology and cytopathology of head and neck, thyroid, and salivary gland tumors, as well as the application of molecular testing in these settings. In this webinar, we will cover the role of nuclear atypia in determining the risk of malignancy of AUS thyroid nodules, evaluate the clinical impact of molecular testing on their management, and discuss the potential benefits of implementing a binary subclassification system for these nodules in clinical practice. Beginning from the introduction of the paper, the Bethesda system for reporting thyroid cytopathology classifies thyroid FNAs into 6 categories, each with the risk of malignancy to guide patient management. Cases in the Atypia of undetermined significance, or AUS, show focal and/or mild abnormalities, not clearly benign, but insufficient for follicular neoplasm or suspicious for malignancy categories. AUS is a low-risk, indeterminate category with a risk of malignancy of 13 to 30% between benign and suspicious for malignancy categories and overlapping with follicular neoplasm category. The AUS management includes conservative options such as surveillance, repeat FNA with a potential molecular testing, two other options such as diagnostic lobectomy. The second edition of the Bethesda system identifies 4 main atypia patterns under the AUS category: mild or focal nuclear atypia, raising concern for papillary carcinoma, which was previously known as cytologic atypia; architectural abnormalities that are insufficient for follicular neoplasm diagnosis; oncocytic atypia falling short of oncocytic follicular neoplasm criteria; and atypia not otherwise specified. As we can observe in this image, nuclear atypia features include nuclear enlargement, chromatin pallor, and occasional longitudinal grooves, but the atypia is milder than in aspirates classified as suspicious for malignancy. Architectural atypia is marked by microfollicles with overlapping nuclei. These aspirates do not qualify as follicular neoplasm due to low overall cellularity or the presence of noticeable, though a smaller fraction of cells with macrofollicular architecture. Oncocytic atypia is characterized by a predominance of oncocytes, though it does not meet the cellularity and architectural criteria typically required for the oncocytic follicular neoplasm category. And lastly, atypia not otherwise specified is illustrated here by a follicular cell exhibiting nuclear enlargement and size variation without concern for papillary carcinoma. Dr. Nishino, my first question for you today is that would you please explain in more detail how AUS not otherwise specified can be differentiated from AUS architectural and, more importantly, AUS-Nuclear, please?
Yeah, I'm happy to. First of all, just thanks so much to the eJournal committee and to everyone logged in to give us this forum to discuss this paper in this post-peer review setting. So to get to your question, what do we mean by AUS not otherwise specified? It's a category that we use very sparingly. For those rare cases that don't show the standard types of atypia that you described really nicely in the past slide. It doesn't show the usual nuclear atypia concerning for papillary carcinoma or the usual architectural abnormalities that raise concern for follicular neoplasm, oncocytic atypia concerning for an oncocytic neoplasm. Or actually one thing that I didn't mention, it doesn't show the monotonous lymphoid proliferation that would raise any concern for a lymphoproliferative disorder. So examples of aspirates that we've called AUS not otherwise specified include samples like this one that you're showing on the screen, where there are a few abnormally enlarged nuclei, yet lacking those nuclear features that we would expect to see for papillary carcinoma. So AUS-Nuclear wouldn't quite fit here, right? And I've also used AUS not otherwise specified for rare cases where we have large, bizarre appearing but stripped nuclei, where without the context of the cytoplasm, really hard to describe it as oncocytic, for instance. So AUS NOS would be a good landing spot for cases like that. And I think the Bethesda system also describes scenarios where an aspirate shows thermometer calcifications, for instance, but without an associated follicular cell proliferation that shows nuclear atypia. So without that nuclear atypia, hard to call it AUS-Nuclear, even though we're thinking about papillary carcinoma. So for cases like that, AUS-NOS would be a good landing spot as well.
Thank you very much for your great comprehensive explanation. I continue with subclassification of AUS. So the subclassification of atypia of undetermined significance based on atypia patterns enhances cancer risk stratification. Previous studies, primarily on surgical cohorts, show a higher risk of malignancy in AUS nodules with nuclear atypia compared to other atypia types. This supports a simplified binary AUS classification distinguishing AUS-Nuclear from all other atypia patterns, or AUS-Other, as recommended in the 3rd edition of the Bethesda system. Adopting AUS subclassification in practice requires knowing institutional risk of malignancy estimates. Is the risk of malignancy of AUS-Nuclear high enough to justify diagnostic lobectomy, or would repeat FNA or molecular testing be better? In contrast, is the risk of malignancy of AUS-Other low enough to recommend surveillance instead of molecular testing? Risk of malignancy estimates based solely on histologic outcomes often overestimate cancer prevalence due to selection bias as most AUS nodules are not resected, and those resected typically show concerning preoperative findings. To address limitations in risk of malignancy estimation, the authors had a prior analysis of 279 AUS nodules using molecular and histologic endpoints. The nodules were tested by the Afirma gene expression classifier and had a 14% risk of NIFP and cancer for nuclear atypia and 6% for architectural atypia, although they were not statistically significant. The current study expands the cohort to 559 nodules, incorporating the newer genomic sequencing classifier to evaluate whether fourth-year or binary AUS subclassification effectively stratifies patients into clinically meaningful groups. Between 2013 and 2021, the authors maintained a database of thyroid FNA samples tested with Afirma GEC or GSC. At EIDMC, the selection of nodules for molecular testing is a two-step process. Nodules meeting clinical or sonographic FNA criteria undergo an initial biopsy for cytologic evaluation. If classified as AUS or follicular neoplasm, a subset undergoes repeat FNA for cytology and potential molecular testing based on the treating clinician's discretion. The Bethesda system classification of the repeat sample determines whether it is sent for Afirma testing. My second question for you, Dr. Nishino, is that could you please explain the differences between the Afirma gene expression classifier, GEC, and the Afirma genomic sequencing classifier, GSC? And how did you decide to group these results based on these two types of tests for a larger sample pool?
Yeah, so the Afirma test has really evolved over the years. So the GEC, the gene expression classifier, was the original version of the test, and the GEC was replaced around 2017 with an updated version of the test, which was called a genomic sequencing classifier, or GSC. And both of these tests examine the expression profiles of a large number of genes, and it uses machine learning algorithms to classify aspirates pretty much in a binary way, as having either a benign gene expression signature or a suspicious gene expression profile. But the methodology and the scale of these tests differs. The original version of the test, the GEC, used a cDNA microarray expression profiling, looked at the expression profiles of just around 140 genes, and then tried to stratify nodules as benign or suspicious based on how those 140 genes or so were differentially expressed. Now, with the current version of the test, the genomic sequencing classifier, that uses high throughput RNA sequencing to measure the expression profiles of like over 10,000 genes. And it uses a little over 1,100 genes as their core classifier model. But you can see the scale of comparing the expression profiles of 142 genes to over 1,100 genes. Adds a little bit more to the risk stratification process. And in the validation studies, the GEC and GSC have a pretty similar, very high negative predictive value and high sensitivity for cancer. But the current version of the test, the GSC, seems to offer a better specificity for cancer and better positive predictive value as well. Now, for the purposes of this study, we used molecular testing as a way to address that long-standing challenge of how to estimate the risk of malignancy for nodules in the AUS category. And Reza, as you had really nicely mentioned, the traditional ways of calculating risk of malignancy was by dividing the number of histologically proven cancer by the total number of surgically resected cases in a particular cytologic category. But the problem is that many thyroid nodules classified as AUS are not surgically resected. So if we calculate the risk of malignancy using only that highly selected subset of cases of those AUS cases that underwent surgical resection, then that could result in an overestimate of the risk of malignancy calculations for that category. So in an effort to overcome that type of selection bias, we argued in that previous paper that you mentioned that a benign Afirma result, whether it's using the GEC or the current GSC, was an informative outcome that could be used as a proxy for benignity in these risk of malignancy calculations. And because of the Afirma test's very well-established high negative predictive value. So we explored this notion of combining a benign Afirma result with histologic outcomes, and we kind of validated that in the GEC-based study that we published back a couple of years before this paper. And then we saw promising results, and we decided to expand that cohort to include the more recently tested GSC cases as well. And since the negative predictive value of both the GEC and the GSC are similarly high, it made sense for us to group both of these together.
Very interesting to know. I really appreciate your answer to this question. From June 2013 to January 2021, repeat FNA samples with cytology classified as non-diagnostic, benign, AUS, or follicular neoplasm were submitted for Afirma testing beginning in January 2021. Nodules classified as cytologically benign on repeat FNA were no longer sent for Afirma testing. I was actually curious, Dr. Nishino, why did you stop sending benign cases for molecular testing on repeat FNA since January 2021? And what was the underlying reason for this approach?
Yeah, so that goes back to our historically kind of determined process of using two steps for selecting nodules for molecular testing, where a patient shows up with a thyroid nodule. The initial FNA of a nodule is for cytology only. We don't collect anything from molecular testing. And for that subset of patients whose nodules are classified as AUS or follicular neoplasm, then they return for a repeat FNA, at which time the second sample is collected for cytology and for molecular testing. And back 11 or 12 years ago, when this two-step approach was first being discussed and developed at our hospital, there was some early evidence suggesting that a thyroid nodule that was classified as AUS on the first FNA, but then reclassified as benign on the repeat FNA, had perhaps an intermediate risk of cancer between that of a cytologically benign and AUS nodules, so somewhere in between. And this type of analysis was often done in limited studies that had only surgically resected nodules. So I think there was a component of that selection bias that we just talked about. But anyhow, based on this notion, we had decided to send for Afirma on the repeat FNA sample as long as that repeat FNA was not suspicious for cancer or positive for cancer. And for all other interpretations, including those that were reclassified as benign on the repeat FNA, we had a pretty permissive policy of sending for the Afirma test. Now, and it's just important to keep in mind also that this was at a pretty early time when these molecular tests were starting to be used clinically, and we had pretty limited experience. I think we had a more inclusive policy for testing. But just about 5 or 6 years ago, we decided to study the outcomes of these molecular tests and correlating the molecular testing results with the repeat cytology results, clinical outcomes, and surgical outcomes. And one of the key findings from that audit was that nodules that were reclassified as benign on the repeat FNA had a very low risk of cancer, and molecular testing did not seem to offer that much benefit in that setting. So based on this internal study, we decided to adopt a more restrictive approach to Afirma testing, and we started to forego molecular testing for those cases where the repeat FNA was benign.
It was great to learn from you about this. Thank you.
Sure.
This study includes thyroid nodules classified as AUS on initial FNA with repeat FNA samples submitted for Afirma testing. It analyzed 559 AUS nodules from both the Afirma GEC and GSC testing timelines, expanding on findings from a prior study of 279 AUS cases from the GEC testing timeline. Thyroid FNAs in this study were classified as AUS-Nuclear, AUS-Architectural, AUS-Oncocytic, or AUS not otherwise specified, based on the Bethesda system criteria, with combined nuclear and architectural atypia included under AUS-Nuclear. No case was classified as AUS due to suspected lymphoma. Patient demographics, nodule size, and Afirma GEC GSC molecular testing results were documented, aligned with histopathologic diagnoses for resected nodules. Now, let me return to you, Dr. Nishino, with additional questions. Why did you not consider recategorizing the AUS oncocytic and AUS not otherwise specified cases with potential, nuclear atypia into the AUS-Nuclear category, similar to AUS architectural, if such cases exist in your cohort?
So if I understand correctly, and to rephrase it, are you asking why did our study subdivide AUS-Nuclear versus everything else? And not try alternative combinations like AUS architectural atypia versus everything else?
Well, no, I'm just trying to see that, did you have, in your cohort, did you have any AUS oncocytic or AUS not otherwise specified with, with features of AUS-Nuclear, comparing AUS-Nuclear, characteristics?
Got it. Yeah, so any case with nuclear atypia, the default was to classify it as AUS-Nuclear, whether there were some oncocytic features and things like that. If we had classified something as NOS, and those cases were quite uncommon in this cohort. If it showed any hint of nuclear atypia of papillary carcinoma, we would have put it in the AUS-Nuclear category. And I think that was based on just studies, over the years that have shown that if there is any nuclear atypia within the group that we classify as AUS, that is an important finding to document because of its association with a higher risk of malignancy.
Understood. Thank you so much. Nodule size and location were used to correlate aspirated nodules with resected ones. Selected cases underwent a slide review to confirm NIFP diagnosis based on 2018 NIFP criteria. For this study, follicular tumor of uncertain malignant potential and well-differentiated tumor of uncertain malignant potential were grouped with NIFP. The outcomes of thyroid nodules were determined using molecular and histopathology criteria. For unresected nodules, those with benign results on Afirma testing were classified as low risk due to the high negative predictive value of Afirma GEC and GSC tests. Nodules with suspicious or non-diagnostic Afirma results were categorized as indeterminate. For resected nodules, final outcomes were based solely on histopathologic diagnosis, regardless of molecular testing results. Resected nodules were classified into three groups: histologically benign, NIFP, or cancer. Altogether, the final outcome of the nodules in this study were low-risk outcomes, including resected nodules that were histologically benign or unresected nodules with benign molecular profiles, indeterminate outcomes, including unresected nodules with suspicious molecular profile or non-diagnostic molecular testing results, and NIFP or cancer. During the study period, the institutional AUS rate was approximately 18%. A total of 713 aspirates from 681 patients were submitted for Afirma GEC or GSC testing, with 10 nodules undergoing testing twice. This resulted in 703 unique nodules being evaluated, of which 559 were classified as AUS on initial FNA. The distribution of Atypia types were AUS-Nuclear 52%, AUS architectural 36%, AUS oncocytic 10%, and AUS not otherwise specified 2%. As shown in table 1 of the article, this study analyzed patient demographics, nodule size, Afirma results, and resection rates across the 4 AUS subtypes. There was no significant difference in patient age or nodule size among the subtypes. Most nodules, approximately 77%, were from women, with a higher proportion in the AUS architectural subtype compared to AUS-Nuclear. However, the proportion of women in AUS architectural was not significantly different compared to AUS oncocytic and AUS not otherwise specified. The overall benign molecular testing result rate for AUS cases was 65%. AUS architectural had a significantly higher benign call rate compared to AUS-Nuclear and AUS-Oncocytic. Correspondingly, the surgical resection rate for AUS architectural nodules was significantly lower than AUS-Nuclear and AUS-Oncocytic. So I have two questions for you, Dr. Nishino. The first one is that, what is your opinion regarding the higher molecular benign call rate of AUS architectural compared to other AUS subcategories? Based on your experience, why might such cases be overcalled more frequently?
Yeah, so in the context of thyroid molecular testing, the benign call rate refers to the number of nodules with benign or negative molecular testing results divided by the total number of tests that were performed. So the benign call rate of a test should be inversely proportional to the prevalence of cancer in the tested population. So for instance, if we ran the Afirma test only on nodules that were classified by us as cytologically malignant, if we ran the Afirma test only in that population that should have a very high prevalence of cancer, then we would expect that most of the Afirma test results would come out as positive or suspicious, right? And the benign call rate would be quite low. So higher prevalence of cancer, lower benign call rate. Then on the other hand, if we do the Afirma test only on nodules that we classify as cytologically benign, where the prevalence of cancer is expected to be quite low, then we would expect that the vast majority of those Afirma tests would come up with benign result, right? So very low prevalence of cancer, very high benign call rate. So you can see how the prevalence of cancer in the tested population impacts metrics like benign call rate, as well as predictive values, negative predictive value and positive predictive value. So with this background in mind, the very high benign call rate, nearly 80%, for the AUS architectural atypia category, compared to 56% for the AUS-Nuclear category. This is likely telling us that the prevalence of cancer in nodules that we classify as AUS architectural atypia must be very low, right? So higher benign call rate must correspond to lower prevalence. So, and you had mentioned, does this mean that cytopathologists are overusing the AUS architectural atypia category? No, I think that's an interesting observation. I think, why would cytopathologists overuse AUS-A, or AUS architectural atypia? I mean, part of that could be the absence of reassuring cytologic features like abundant colloid or macro follicles in an aspirate. And if it's a scantily cellular aspirate and all we see are small crowded groups, we might be inclined to call it AUS and say, it's because of the architectural atypia. I think there is a prevailing mindset among many of us of not wanting to miss a potential cancer. And that might be contributing to the overuse of the AUS category. And, so I think studies like this one could show us that the AUS architectural atypia category is actually quite low risk, especially when you consider all the nodules that have benign Afirma results in that category. And it might be telling us that if you have an aspirate that straddles that benign or AUS architectural atypia, it may be safe for us to put it in the benign category. And I think studies or observations like the one you made are the ways that we could incrementally, improve the way that we report thyroid cytology.
It completely makes sense. Thank you. And one additional question here is that the benign call rate for AUS oncocytic nodules approximate that of AUS-Nuclear rather than that of AUS architectural, even though the risk of malignancy for AUS oncocytic nodules more closely approximate that of AUS architectural than AUS-Nuclear. Can you just, speculate on this discrepancy, and what is your institutional experience for the outcomes of resected oncocytic nodules?
Yeah, no, that's a really keen observation to glean from this table. Yeah, so basically pointing out how if you look at the Afirma results benign line, 56% of AUS-Nuclear was called benign, similar to the 57% of AUS-Oncocytic that was called benign. So similar benign call rates. So does that mean that the prevalence of cancer in these two categories are similar? That's not what the data showed. It showed that AUS-Nuclear has a much higher risk of malignancy compared to AUS oncocytic. So how do we explain that? The older version of the AFIRMA test, the gene expression classifier, had this tendency to call benign oncocytic proliferations as suspicious. So the older version of the AFIRMA test was pretty well reported, throughout several studies to have the older version of the AFIRMA test had a tendency to have a low positive predictive value, a lower specificity for oncocytic tumors. So what that means is if you had a benign oncocytic proliferation, more often than not, AFIRMA GEC would call it suspicious. But then when it was resected because of that AFIRMA call, the surgical pathologist often called it oncocytic adenoma or a hyperplastic nodule with oncocytic features. So that probably explains why the benign call rate for oncocytic tumors was very low, but on resection, the cancer rate was quite low as well. So the more recent version of the AFIRMA test has addressed this issue to a large degree by adding additional markers to help risk stratify oncocytic nodules better. But yeah, I think your observation is mainly due to the impact of the GEC, the older version of the test.
Great to know. Thank you for explanation.
Sure.
Table 2 of the paper presents demographics, nodule, molecular testing, and resection data using a binary classification based on the presence or absence of nuclear atypia. The difference in gender distribution between AUS-Nuclear and AUS-Other was statistically significant. Additionally, the distribution of benign versus suspicious AFIRMA outcomes was statistically different between AUS-Nuclear and AUS-Other. Now in figure 2A, nodule outcomes are presented based on a 4-tier subclassification scheme for AUS, which includes both molecular and surgical results. Resected nodules identified as NIFP or cancer are grouped together, shown as blue bars. Resected nodules with benign histology are combined with unresected nodules that had benign AFIRMA results, collectively representing low-risk outcomes, which are orange bars. Unresected nodules with suspicious AFIRMA results or non-diagnostic / testing not performed results are categorized as indeterminate outcomes, shown as gray bars. Now in section B of the figure 2, the histology classification of resected nodules is summarized by AUS subcategory and AFIRMA results. In the overall AUS study population, the prevalence of histologically confirmed NIFP and cancer was 13%. In the resection cohort, papillary thyroid carcinoma was the most common malignancy, with most PTCs initially classified as AUS-Nuclear. And among the 27 NIFP cases, 22 were classified as AUS-Nuclear. 328 unresected nodules with benign AFIRMA results were considered low risk and grouped with 116 histologically benign nodules. 30 and 13 unresected nodules with suspicious or non-diagnostic AFIRMA results, respectively, were classified as indeterminate outcomes and excluded from NIFP cancer prevalence calculation. The prevalence of NIFP cancer was 21% for AUS-Nuclear, 6% for AUS-Architectural, and 8% for AUS-Oncocytic, and no NIFP or cancer cases were found in the 9 AUS not otherwise specified cases with molecular or histology follow-up. Now in figure 3 shows nodule outcomes based on a binary AUS subclassification scheme. The prevalence of NIFP cancer was significantly higher in nodules classified as AUS-Nuclear, 21%, compared to AUS-Other, 6%, based on both molecular and histologic endpoints. Now in figure 4, as shown in figure 4, the prevalence of NIFP and cancer was calculated using a binary AUS subclassification scheme, AUS-Nuclear versus AUS-Other, with both histologic and combined molecular and histologic endpoints. Relying solely on histologic endpoints, as mentioned earlier, overestimates the risk of NIFP and cancer, including unresected molecular benign nodules, provides a more clinically accurate representation of the AUS population for calculating the risk of malignancy. When considering only surgically resected nodules, the prevalence of NIFP cancer was 47% for AUS-Nuclear and 23% for AUS-Other. Now, beginning the discussion part, authors in this retrospective study demonstrated that a binary reporting scheme based on nuclear atypia effectively risk-stratifies the AUS category. The institutional prevalence of NIFP and cancer was 21% for AUS-Nuclear and 6% for AUS-Other. The differences in NIFP cancer prevalence among AUS subtypes without nuclear atypia were not statistically significant, supporting their combination into a single AUS-Other category for risk of malignancy stratification. Histopathologic classification has traditionally calculated risk of malignancy for the Bethesda system categories with high resection rates, but it overestimates risk of malignancy for lower resection categories like AUS. To improve this, molecular test results are now included in risk of malignancy calculations for indeterminate categories like AUS. One more question here for you, Dr. Nishino, is that in settings where molecular testing is not an option, is not available, do your results support a specific approach that can be followed based on cytomorphologic findings alone, such as nuclear atypia?
Yeah, I think so. You know, in countries where molecular testing is not used routinely, clinical and sonographic features and this type of cytomorphologic subclassification seems to play a bigger role in guiding treatment decisions. And you know, our findings aren't new, but they do support the notion that AUS cases with architectural atypia or oncocytic atypia might be relatively safe to observe in the appropriate clinical and sonographic setting, while those with nuclear atypia may require more urgent intervention or more close monitoring with repeat FNA or perhaps a limited panel molecular test and so forth.
Of course, thank you. Additionally, the authors emphasize that these studies utilize the high negative predictive value of molecular tests for thyroid FNAs and routine molecular testing of AUS nodules to include nodules with negative molecular results in risk of malignancy calculations. This approach uses negative results as a proxy for low-risk outcomes, making risk of malignancy calculations more representative of the broader thyroid FNA patient population rather than just those selected for surgery. Compared to a previous study of 279 AUS cases tested with the Afirma GEC, this study included nearly double the sample size by adding 280 AUS cases tested with the Afirma GSC. With the larger cohort, the difference in NIFP cancer prevalence between AUS-Nuclear and AUS architectural, which was not statistically significant in the prior study, now has been more pronounced. Due to the modest positive predictive values of both the GEC and GSC versions of the Afirma test, unresected nodules with suspicious results were considered inconclusive and excluded from risk of malignancy calculations, aligned with 2% of AUS samples with inconclusive results due to test cancellation or insufficient RNA. This exclusion reduced the sample size used for risk of malignancy calculations. To address this limitation, the molecular-derived risk of malignancy method, or MDROM, which estimates risk of malignancy based on weighted molecular testing results, can be used. Additionally, tests like Thyroid V3 genomic classifier, which report distinct molecular alterations with associated malignancy probabilities, may provide an advantage in estimating risk of malignancy for nodules with low resection rates. Dr. Nishino, would you please provide more details about the Thyroid V3 genomic classifier and compare it with the Afirma GEC and GSC, please?
Yeah, so I'll start by saying that both Thyroid and Afirma, these both tests have evolved over the years, and the information that both of these tests provide to the end user, our patients and our treating clinicians, seems to be pretty similar in terms of how they risk stratify thyroid nodules and help guide treatment. So with that as our backdrop, the main testing approach differs between these two tests. The ThyroSeq uses high throughput targeted next generation sequencing to mainly look for mutations and gene fusions and chromosomal copy number alterations that are associated with thyroid neoplasia. And the current version of the test also includes some gene expression analysis, but that's not the main driver of this risk stratification that the ThyroSeq uses. Now, with ThyroSeq, if no alterations are found, then it's considered a very low risk nodule. Whereas if an alteration is found or a combination of alterations are found, then the ThyroSeq result will offer variable estimates of cancer risk, even what type of tumor it is, and if it is likely to be cancer, then what type of or whether it would have aggressive clinical course or not, and a risk of recurrence. Now, Afirma, on the other hand, also uses NGS, next generation sequencing, but next generation sequencing of RNA. It uses the RNA sequencing mainly as a way to measure the gene expression levels, of the thousands of genes in their panel. And then it uses the machine learning algorithms to help analyze whether that gene expression profile is more aligned with a benign nodule or a nodule that's not benign, or not clear-cut benign. But because RNA sequencing can also be leveraged to extract qualitative data about a gene sequence, if the RNA sequencing process also identifies a mutation or gene fusion that's known to be associated with thyroid neoplasia, then those results can be used to help refine the risk stratification beyond the kind of binary classifier that Afirma is known for.
Great to know, thank you. In the discussion, authors also referred to another study by Geiser that used ThyroSeq results to calculate the molecular derived risk of malignancy for AUS subcategories, finding that AUS cases with nuclear atypia had a 28% molecular derived risk of malignancy compared to 15% for other atypia types. While the current study's result aligned with Geiser's study, current study takes a different approach by combining both molecular and histologic results to calculate an integrated risk of malignancy estimate for each AUS subclass. Additionally, unlike Geiser's study, the authors included histologically confirmed NIFP along with cancer cases in risk of malignancy estimate, as NIFP is currently considered a condition for which surgery is appropriate. Institutional differences in how thyroid nodules are selected for molecular testing may explain variations in cancer prevalence between studies. Geiser reported that all cytologically indeterminate thyroid FNAs at their institution were reflexively tested, while at the author's institution, molecular testing is not automatically performed. Instead, whether to proceed with Afirma testing is decided by the patient and clinician, often after a repeat FNA. In a previous study, about half of patients with indeterminate cytology on initial FNA underwent repeat FNA for Afirma testing, while others were managed with surveillance, additional ancillary tests, or surgery. While incorporating molecular testing results improves the accuracy of risk of malignancy estimates in this study, it also introduces a selection bias by limiting the cohort to Afirma tested nodules. For example, the study did not include cases classified as atypical lymphoid cells. On initial FNA, 9 cases from 8 patients, as these were typically followed by a repeat FNA or core biopsy with flow cytometry, rather than Afirma testing. As a result, these cases were not part of the study. And lastly, the authors concluded that this analysis of AUS nodules with conclusive molecular and histologic outcomes supports using a binary AUS subclassification based on nuclear atypia. The distinction between AUS-Nuclear and AUS-Other suggests different clinical management approaches for each subcategory. The 21% NIFP cancer prevalence in AUS-Nuclear aligns with clinical validation studies of Afirma GEC and GSC, supporting continued molecular testing for these nodules. For AUS-Other nodules, the low prevalence of new precancer suggests that active surveillance may be appropriate for certain patients depending on their clinical and sonographic characteristics. Now, we have 50 minutes, good time for Q&A session. If the attendees have questions from Dr. Nishino.
Yeah, while we're waiting for the questions to roll in on the chat, first of all, I just wanted to thank you, Reza, Dr. Lee, Dr. Heyman, just for having a forum like this. You know, because when we talk about peer review, you know, we often think about that pre-publication peer review, the discussion between the authors and the experts and the editors, and it's all the work that goes behind making the manuscript as good as possible, you know, prior to publication. But you know, a forum like this that provides this post-publication peer review is equally important. And I love this idea of engaging one of the authors, you know, in this process, because it helps us understand where there are areas that require clarification, and I think collectively it'll help us incrementally make our field better.
You're very welcome, Dr. Nishino.
Yeah. I just had one comment. Yes. Yeah. Thank you so much for this excellent presentation. Really, a lot of clinical information and very well summarized, and can guide our daily practice. So I just have one comment I want to hear from you, expertise or your experience. So in recent years, like, you know, 1 or 2 years, we saw quite a lot young patient, like, you know, the trend towards younger patient has this thyroid nodule, and after FNA, we saw some AUS category is more often in our institution. I didn't do a detailed study, but in my impression, like in a lot of those younger patients, in AUS category, more often, you know, we found oncocytic atypia. Oh. And also, I mean, this trend in thyroid cancer, we saw a lot of younger patients. It's also, you know, cross-board for all the solid tumor. Now, in this 2 or 3 years, we saw more younger patient has, you know, cancer. So what are your opinion, like, you know, if you look younger patient population, for example, 30, 20 compared to elderly patient, 60, 70, any, you know, this guideline, you know, is it still the same or a little bit different?
That's a really interesting question, and also observation about the age of the patients. You know, I think traditionally we've thought of papillary thyroid carcinoma as a disease of relatively young adults. You know, I think 20s, 30s wouldn't be, you know, too unusual, you know, from the cases that we see. You know, I think when we move into the pediatric population, you know, so patients under 19, for instance, I think there is this recognition that the same, I guess the same cytologic criteria that could be used for classifying these, you know, using the Bethesda system, but the risks of malignancy tend to be higher, you know, for the pediatric population. So, you know, perhaps we could extrapolate that to say, you know, when we see aspirates in you know, patients from the early 20s, for instance, that, you know, maybe it could be associated with a somewhat higher risk. I think on the opposite end of the spectrum, you know, whenever we see a thyroid FNA from an elderly or an older male patient, we often will think, you know, this is not the typical demographic for someone who may get your garden variety papillary thyroid carcinoma and might start thinking about something that's a little bit more aggressive. So I think that's an important consideration. And, you know, I think to the extent that molecular testing is now being used to risk stratify these patients a little bit more, you know, for example, if we find just an isolated RAS mutation or maybe even a dicer mutation you know, in an aspirate from a younger patient, that might not cause as much concern as, if we identify a TERT promoter mutation, P53 mutation combined with one of the other drivers. So I think to the extent that molecular testing can be done on some of these aspirates, even those that are classified as suspicious for malignancy or positive for malignancy, that might help us understand these younger patients presenting with thyroid cancer.
Thank you so much.
Question. Yeah. Let me take a peek at the chat here, see if there's anything popping up. Yeah, I don't see anything.
So it's tough for me to do this on a phone, which my institution requires that I do, rather than a desktop. It does appear that we do have a question. Joanne, can you see if there's something in the chat?
Oh, I see. Questions in the question box, not the chat box.
You should. There is a question that says, has IHC been considered for cases of AUS with PTC being a potential?
Oh yeah, okay. No, I see that in the chat now. Yeah, thank you. So the question is whether certain immunohistochemical markers like HBME1, for instance, and I think others like CK19, galectin-3 have also been used because they tend to be overexpressed in cases of papillary carcinoma. I'm certain that there have been some studies, either on cell blocks or even on direct smears, using immunohistochemical markers like these to help risk stratify AUS. But I don't use it personally on a routine basis. It could be potentially useful. The one caveat being that these markers are not considered, very highly specific. So it's possible that if you do see an increased HBME1 stain in an aspirate, for example, it could be sampling of reactive follicular cells in the context of chronic lymphocytic thyroiditis. So it is hard, I think, to interpret these cells outside of the context of having the architecture of the entire tumor. A good question, and it would be interesting to see if some studies like that could be done.
There is no other questions in the question that have been submitted.
Thank you, Joanne.
I have a question actually, or Dr. Herman, you can ask the question.
First of all, I wanted to thank you for a terrific presentation, and also Dr. Nishino. You have contributed a lot to the ASC, and including lectures on how these molecular tests work. I'm really always just impressed by all the molecular tests, including the GSC. In addition to the classifier itself, it also does look for a small number of specific entities, parathyroid, medullary, BRAF V600E, and RET-PTC fusions. It's not quite really in the text of this paper, but I'm really just wondering about your institutional experience. Have you seen any of those? If you do they fall into the nuclear or the other categories, or have you not seen them at all in the GSC?
Yeah, that's a really interesting question, because it's these tests are offered as something that could potentially be very useful, but we do find them very or we find positive results very uncommonly. And I think maybe like one case of medullary carcinoma that was detected amongst the AUS and follicular neoplasm cases. I know we've had at least one or two parathyroid detected because of the molecular testing result. I think BRAF V600E we do get every once in a while, detected by the malignancy classifiers. But as your question suggested, these are pretty uncommon, and at least for the BRAF V600E positive cases that we've seen, the vast majority of them have been classified as AUS-Nuclear, but they're still pretty uncommon because BRAF V600E often associated with either tall cell or conventional papillary carcinoma, where the nuclear features tend to be pretty overt, and on FNA classified as suspicious or definitively positive for papillary carcinoma. So those cases just aren't in the AUS pool that tends to be subject to molecular testing.
Terrific. Thank you very much.
Yeah.
If there's no more in the chat, I think we are coming up on the hour. Just want to make sure, Dr. Lee, do you have anything else? Joanne, is there anything else in the chat?
I don't have. Just thank you for excellent presentation.
Nope, there's nothing in the chat. You're good.
If you have, we might have a quick question here. Is that aside from AUS, is there any other Bethesda system category or subcategory for which you might consider having GSC for the purpose of risk stratification, clinical decision making, or even for QA?
Yeah, so we use it for follicular neoplasm. So the main categories is AUS, Bethesda 3, and follicular neoplasm, Bethesda 4. I've seen studies over the past several years exploring whether these tests, Afirma, ThyroSeq, can be used in the suspicious for malignancy and even positive for malignancy categories. I think those are interesting. It's I guess to the extent that if you have, let's say, a papillary carcinoma case where you're considering a lobectomy, but if you identify high-risk alterations like a TERT promoter mutation or P53 mutation together with a BRAF V600E mutation, maybe that could prompt the patient to consider a total thyroidectomy up front. So to the extent that that type of surgical decision-making could be influenced by molecular testing, it may be useful, but I think that area is still emerging. Whether that's the best use of molecular tests in this setting is still left to be determined. Now, QA is interesting. We also have Dr. Heyman here, who is one of our experts in using molecular testing in thyroid FNAs as a quality metric. And I think we've taken a lot of inspiration from how in the gynecologic cytology field, we relied on HPV testing, molecular testing for HPV as a way to help us understand how cytopathologists use the ASCS, or maybe even overuse the ASCS category. And I think studies from Dr. Heyman's group, and we've also tried it ourselves here at BIDMC, whether we can use molecular testing results as a way to better understand, how cytopathologists are using the AUS category and maybe identify, how we can restrict or maybe kind of inform ways to reduce the AUS category. I think you had introduced, Reza, at the very beginning that our institutional AUS rate has hovered around 18%, which is, relatively high, compared to the 10% that's recommended in the Bethesda system itself. So, perhaps, based on studies like this, we can say, okay, this group of AUS with architectural atypia, really sparsely cellular, but just with a few microfollicles, maybe those are better classified as benign. And that's one kind of QA application of molecular testing studies like this one.
Thank you.
Well, thank you. This has been great. I really enjoyed engaging with all three of you, as well as everyone out who's listening.
Yes, thank you guys so much. That was really terrific.
You.
Joanne or Dr. Lee, do we have anything else?
No. Thanks again, and everyone has a great holiday season and a Happy New Year.
Thank you.
Thank you. Thank you.
Thank you, guys.